Dr. Susan Kressly is a board-certified pediatrician and a fellow of the American Academy of Pediatrics. She has a private practice in pediatrics and adolescent medicine in Warrington, Pennsylvania. The American Academy of Pediatrics was founded in June 1930 and has approximately 60,000 members. So another fellow Pennsylvanian, must be Pennsylvania Day here. Welcome.
Thank you very much, Chairwoman Dahl-Kemper and members of the committee. Thank you for your leadership and representation of the 3rd District of Pennsylvania. Many children in Northwest Pennsylvania have been helped by the votes you have cast in favor of the reauthorization of SCHIP and ARA. The Academy also applauds your attempts to find innovative solutions to health IT funding. My name is Susan Kressly, and I'm a practicing pediatrician in Warrington, PA. I'm honored to represent the American Academy of Pediatrics before you today. On behalf of nearly 1/3 of Americans' populations who cannot vote, I would like to express my gratitude to this committee for allowing me the opportunity to give children a voice. After 15 years in a large group practice, in 2004 I started my own small business, convinced that there had to be a better way to create a medical home using technology. I wanted to increase practice efficiency so I could spend more time listening to my patients. My desire to provide higher quality medical care was enabled by the ability to collect and analyze meaningful data, such as patients who are overdue for preventative or follow-up care. My HIT allows me to practice medicine in a way that I always envisioned I could. I know what's possible. More pediatricians need help implementing similar technology. Currently, pediatricians are the lowest adopters of HIT of all physician groups. 60% of pediatricians practice in small businesses like mine. Many of us have found it difficult to purchase health IT systems on our own. A big factor in our inability to afford expensive technology has been the reduced Medicaid payments that most pediatricians receive. According to AAP surveys, Medicaid payments average around 70% of Medicare rates and vary widely from state to state. If a typical Medicare provider sees 20 patients per day, a Pennsylvania Medicaid provider must see 30 patients to earn the same amount, and Congressman Westmoreland Atlanta is the same. In New York, the Medicaid provider burden jumps to 40 patients, and my exhausted colleagues in Chicago must see 50. With Medicaid now covering more than 30 million children, this pace is simply unsustainable. The Academy greatly appreciates the funding included in ARA for pediatricians to purchase health IT. Unfortunately, the statute creates disparities between practices that are paid by Medicaid versus Medicare. First, ARA funds flow differently for the two programs. ARA requires practices to maintain a minimum percentage of Medicaid patients in order to qualify for incentives under that program. This requirement is not imposed on practices receiving Medicare payments. The Academy believes that this requirement should be repealed so that the Medicaid and Medicare incentives are comparable. Second, the definition of meaningful use is treated differently for Medicare versus Medicaid programs. Medicare is defining a single national standard under which a practice will qualify for ARA incentives. On the Medicaid side, it appears that states can create their own definitions. As a result, within a brief time, there could be 56 different definitions of meaningful use in the various state and territorial Medicaid programs. 1/3 of doctors practice near state lines. Under the current statute, they might need to qualify under 2 or more states' meaningful use rules. And I cannot imagine a single EHR vendor who will be willing to write 56 different meaningful use reports for medical practices to submit to their states. The Academy believes that a single national standard for pediatric meaningful use is not only achievable but essential for measuring and improving the quality of health care for all children. We stand ready to work with the appropriate agencies to create such a uniform definition. We would also urge you to consider one other issue that could have immediate impact on the advancement of child health IT. There has been much talk about HIT interoperability. Every state maintains a central immunization registry, and the CDC has defined robust interchange standards for these systems. Yet only a small handful currently offer real-time interoperability with EHRs, and almost none of them talk to each other. Why? Because states lack resources to upgrade their systems and implement those standards. As a result, my pediatric colleagues and I have limited access to this critical public health information. The collected data sits in these massive repositories just beyond our reach when it could be put to meaningful use in short order. This shovel-ready project has significant value to each and every practicing pediatrician, as well as promoting public health goals by improving immunization rates and preventing misuse of healthcare dollars due to inappropriate or duplicate immunizations. Thank you very much for the opportunity to testify before you today. We appreciate this committee's efforts to help small pediatric practices continue our vital mission to deliver high-quality medical care to the nation's children. I will be happy to entertain any questions.